Can you see the slide?
Yes, we can see.
Can you see the slide?
Yes, we can see.
Good evening. Good evening, everybody. And I'm Tharanga Jayathungs, consultant neonatologist currently at Beijing Hospital, Jakarta. So first of all, I would like to thank the Ceylon Association of Neonatologists and the Neonatal Society of Sri Lanka for providing me this opportunity to address this forum. So today's topic is fluid and electrolyte management in neonates. So this is a basic topic, but yet a very important topic in management in neonates. So this is the outline of my topic today. So I'll go through a little bit of physiology with relevant to the fluid management in neonates and the cause of parenteral nutrition, energy needs in a newborn, and how to administer IV fluids and their complications and some special situations. So total body water content in the body. So in an adult, so the total body water content is roughly around 65% to 70%. With extracellular fluid, the volume is around 30-35%. But in neonates, they have higher total body water and as well as higher extracellular fluid. So when the baby born prematurely, the more the premature, they have more total body water. You can see my pointer. So at the initiation of the gestation, very initial period, during the fetal life, they have about almost like 90% of the body weight is comprises total body water, and out of it, 65%, roughly around 65% extracellular fluid. But with the growth and with the addition of protein and lipids in the body cavity, so this total body water and extracellular fluid gradually decrease with time. So when the baby is about to deliver, so there are some physiological changes which happen. So we call the neonatal transition. So with that, with the hormonal involvement and as well as the help of the immature kidney, and this total body water become less and extracellular fluid contraction happens. Then the renal blood flow, the cardiac output will be increased, and at the same time, the renal blood flow increased. With that, diuresis happens. So we are targeting this neonatal postnatal diuresis. So it is an important entity when considering IV fluids. So we'll see. So the main difference in this picture is the neonates, and they have higher total body water and as well as extracellular fluids. And especially if the baby born prematurely, the body water content and the extracellular content is high. So what are the indications for intravenous fluid in a neonate? So you all know that so once the baby born, so complicated term baby, so baby will swim and discharge home. So that's the normal scenario. But in some instances, some babies requiring additional support where the baby needs to be admitted to a neonatal care unit. So especially if the baby born prematurely, then we might have to admit, especially if the baby born less than 32 weeks or less than 1500 grams, they want IV fluids and also the nutrition. As well as any sick baby who's not tolerating enteral fluids, we need to start IV fluids, and any surgical condition which prevents starting enteral fluids. So they need to consider IV fluids, severe dehydration or shock in newborn, or severe perinatal asphyxia, or who suffer from hypoglycemia, severe hypoglycemia, and as well as some babies who requiring incubation and medication. So those are some of the babies that requiring IV fluids during the newborn period. So what are the goals of the parenteral nutrition or the IV fluids? So our main goal is the ultimate target is to match the nutritional supply which already received during the intrauterine life fetus, to match that, and to match that nutrition supply and give that same supply, try to give the same supply to the neonate to achieve the adequate growth. So this will, so if we provide adequate optimum IV fluids or parenteral nutrition, this will reduce the risk of severe weight loss, and it will improve the growth and the neurodevelopmental outcome, as well as this will reduce the mortality of the newborn. At the same time, this will reduce the incidence of necrotizing enterocolitis or the pulmonary dysphasia happening to the newborn. So, what about the weight of the newborn? So, we all know that we anticipate a weight loss by day 10 in a term maybe around 7 to 10% of weight. We anticipate 7 to 10% of weight loss. That's called weight loss. And as but in the preterms, that is, we anticipate around 10 to 15%. And this is happening mainly because of the contraction of the extracellular fluid that I have already mentioned previously. Because if the baby is preterm and they have an immature skin, and so there's high tendency to lose free water from the water, especially from the extracellular fluid, and as well as sometimes from the intracellular fluid as well. But not only the preterms, term babies also at risk of losing this excessive weight loss can happen if we not provide additional support. So additional support in the sense, especially for preterm, so to prevent the insensible loss from the excessive insensible loss from the skin, so we can provide humidified, heated humidified air for the respiratory support, and as well as humidification in the incubated air up to 85% of humidification we give, so we can minimize that excessive water loss. So when we calculate weight, you all know that in neonatal practice, not on the neonatal practice, pediatric practice, we calculate most of things according to the weight. So we take the birth weight for the neonates until the baby is regaining weight. So we take the birth weight to calculation weights, and as well as other drug calculations as well. And when we increase weight, so I will discuss this later on as well. So when we increase weight, so we have to make sure there are postnatal diagnosis and weight loss prior to increasing weight. I will discuss this later as well. So this is a rough guideline. So this is from our local guideline, the national guideline.
Hello, Tharanga.
So
Your
yes.
sound, your sound is not very clear. I think better to take.
Can you hear me?
Yeah. Now it's okay.
Right. So sorry for the interruption. So the fluid requirement. So this is a rough guideline, which is from the national guideline for care. This is just a guideline, so which give an idea about how to start IV fluids for a baby. So this demarcates by the baby, but also it can be taken as preterm to term baby. So if babies below 1500 grams, so those babies requiring additional support. See, at day one, they require about 80 ml per kg per day of IV fluids, while the term counterpart needing just 60 ml per kg per day, because the difference is because of the excessive insensible loss that we anticipate because of the mature skin and because of the other associated environmental factors like hyperthermia, etc. So then gradually we increase weights by day 2, 3, 4, 5, 6, 7. So our ultimate target is to achieve 150 by day 5 to 7. So with the gradual increment, so the weight increase increment is guided by not on this chart actually. So we have to make sure, as I said earlier, so we should get postnatal diuresis. So, and as well as the weight loss. So the important thing is if we are carrying the baby in an incubator, if we have the facilities for inbuilt weight scaling facility, then we can check the weight and the weight loss. We can check easily. But otherwise, if it is a term baby, sometimes we use formers. In that case, we have to manually check the weight. So ideally, we have to check the weight daily basis initially. But sometimes in sick preterm, extreme preterm babies, we might have to check the weight 2 times per day. That's depending on the clinical situation. So that will guide the weight balance actually. So if we notice a weight loss, then and as well as if we notice a urine output, so how can we measure a urine output in a new baby, especially in a preterm baby? So we are not catheterized, you all know that. So we just check the pamper weight, so we can check the dry pamper weight and the weight pamper weight and get the difference and the gram. So gram is equal to 1 mil, so we can think like that and we can calculate the urine output. So if we demonstrate, if we are able to demonstrate a postnatal diuresis, then we are in the right track. So we anticipate that extracellular fluid volume contraction. So the postnatal diuresis is happening. So now we are safe to increase fluids. So then we can increase fluid by the day 2. And but in some instances, this physiological adaptation, the physiological contraction won't happen in conditions like respiratory distress syndrome. So for other conditions like extreme preterm babies, because of the immaturity of the renal system and as well as excessive skin, hormonal imbalance. So the hormones are not working properly, like the aldosterone, catecholamines, those are not working properly. In those patients, sometimes those postnatal diuresis won't happen. So it will take a little time. So if sometimes they gain more weight because the intracellular fluid shift to interstitial fluids. So in those patients, if we increase fluids, then the weight gain will be there, which is going to be problematic because gaining weight is not good during the initial periods. That will may cause problems for persistent EPA, or they are at risk of developing it in future, and as well as they are at risk of developing bronchopulmonary dysphagia. So we have to, so very important point. So we have to make sure there's postnatal diuresis and as well as weight loss to increase the fluids. So then after day 2, and when we start in day 3, then we demonstrated further diuresis and weight loss. Then we think that sodium also start losing, and so by this time we consider starting our electrolyte, as you know. So I'll come to the slides. So what are the choices for IV fluids? So you all know the breast milk is the best, so no question about that. But unfortunately, some instances, as I said earlier, we can't start that. So in those instances, we have to consider other options. So if we are considering IV fluids or parenteral nutrition, so it should be commenced soon after birth. So that will facilitate the neonatal growth rates, which is similar to normal fetal growth rate, so which is physiological and it will improve the outcome of the baby. And usually in a preterm baby, the energy requirement is roughly around 120 to 130 kilocalories kg per day. So that's coming from the resting energy expenditure, which is around 50 kilocalories kg per day. And as well as to grow new tissues, they need more energy. So about 67 to 80. So altogether, so they require 120 to 130 kilocalories per day. So we need to match this requirement and provide the adequate fluids to match this requirement. So how can we match this requirement? So we can, so we use 3 macronutrients for that: proteins in the form of amino acids, lipids, and the glucose, dextrose. So as I said earlier, so the amino acid has to be provided soon after birth. This will improve the cognition and the brain growth of the baby, and as well as it will prevent the protein breakdown. So negative protein balance won't happen, and as well as it will promote the growth and remodeling of the cells. not only providing amino acids, it's very important that we have to start some form of non-protein energy with amino acids. Otherwise, the protein will be utilized for the energy requirement and protein will be oxidized. So the ultimate goal of the protein won't happen. So because of that, we have to we need to start with some form of non-protein energy like lipids and dextrose. So the minimum is to start at 1 gram per kg per day of protein together with the non-protein energy of 30 kilocalories per kg per day of dextrose. And this will prevent the negative nitrogen balance, as I said. So the lipid requirement is like this. So that's the high energy density supplier. So which gives 1 gram gives 9 kilocalories of energy. And also it provides essential fatty acids for the brain development, which is a very important entity. And it has to be started like 0.5 to 1 gram per kg per day, then gradually we are increased. So ideally it has to be started within 72 hours to prevent essential fatty acid deficiency in the newborn. But we have to be cautious when the baby is having unconjugated, severe unconjugated hyperbilirubinemia, where the baby is at risk of severe jaundice, unconjugated jaundice, or probably visas disease or APO incompatibility. So because the lipids displace the albumin and will put those babies at risk of developing recession. So we have to be careful when we start lipids on those babies. And the carbohydrate, the next macronutrient is the carbohydrate. So we provide carbohydrate as dextrose. So for that, we have to calculate the glucose utilizing rate or the glucose infusion rate. So can be calculated by the percentage of glucose, body weight, the fluid rate, and into. So there's a typo error. Sorry for that, and it has to be multiplied by 0.007. But you can find in calculator to calculate this glucose infusion rate. There are apps like Niku Tools, or you can Google Niku Tools. So many apps are there nowadays to calculate this glucose utilizing rate. So it is very easy. You can just type the type of weight, it will give the values easy. So preterms have higher glucose utilization rate than the term because they are born preterm, and mainly the most of the macronutrient deposition happens during the third trimester. So because they are born preterm, so they are lacking the glycogen storage and as well proteins and lipids. So because of that, because of lack of glycogen storage, we have to supply high glucose utilization rate for these babies for their optimal growth. So their rate is 6 to 8 milligram per kg per minute. So considering all these things, if we provide 10% dextrose 6 to 8 ml per kg, that's the day 1 fluid. That will provide 4 to 6 milligram per kg per minute of glucose utilization rate. So that is bigger for both term and the preterm babies. So that's why if we give 5% or below that dextrose concentration, that energy supply is not adequate. So that's why we use 10% dextrose in neonates. And what about the other fluid, electrolyte and multivitamins needs? So unfortunately, we have in Sri Lankan setup, we provide total parenteral nutrition that comes only with protein, lipids, and dextrose. But we don't have the facilities of providing DPN bags like other countries, which has added electrolytes and as well as added vitamins of those bags. Don't have that facility, but that's fine. So we are managing without those things at the moment. So as I said earlier, so during the first few days we are starting 10% dextrose because we are anticipating pre-water diuresis and electrolytes are not added. So we anticipate 10 to 15% dextrose by this time. So even though the water loss is there, their fractional excretion of sodium is not high, and because of that, they are at risk of hypernatremic dehydration. That's why it's important to give some form of fluid if the baby is sick. But otherwise, if baby can be PET, so it can be overcome easily. So then start at 6 to 8 ml per kg per day on day one, then gradually we increase. So increment is like 10 to 20 ml per kg per day. So we are increasing like that, but depending on the clinical situation and the clinical parameters of the baby. And so in next few days, the extracellular fluid further contracts and the aldosterone also stimulated, but aldosterone responsiveness is not adequate. Though the aldosterone is there, but they still lose sodium. So the fractional excretion sodium is around 1 to 3% because the renal immaturity. So now they are at risk of developing hyponatremia. So that's why we add the sodium and the other electrolyte, potassium and calcium for the fluids after with the battery is starting. So those are important points. And so once we start fluids, then we can consider starting EPM. At the same time, we can start EPM. So I will discuss these things later on. And as well as gradually we can grade up on feeds if baby tolerates feeds. Then if baby tolerates, then we can add into the fluid regime, and we can reduce the IV fluids requirement. So our target is to achieve 15 to 20 grams per day of weight gain, and as well as if it is a preterm baby, once after 2 to 3 weeks of time, because of the renal immaturity, they may lose sodium more. So sometimes they become hyponatremic and might have to give additional supplements other than the normal demand for the baby. So, and as well as to achieve the weight gain, it might have to increase the fluid regime, not only the 150, so we might have to increase further up to maybe even up to 220 ml per day. But usually that's the intravenous. So usually we maximally we give weights of 160 ml per day, but then gradually we increase further by enteral feeds. So vitamins, as I said earlier, so we don't have facilities of vitamins in our TPN bags, but we provide vitamins for babies at risk, especially less than 2,500 grams and as well as less than 37 weeks born babies. We give them vitamins in the form of multivitamin drops, 0.3 ml, 0.3 cc daily. Once the baby achieves full feed, we start them, and as well as once the baby achieves full feed and reach day 14, we start iron for the baby as well. So on top of we give folic acid for the baby as well. So what fluids to be started? So as I said earlier, so in the first 48 hours is the 10% dextrose. So after 48 hours, once the postnatal diuresis happen and as well as weight loss is there, then we add sodium, potassium, and calcium to the fluid regime. So this is the way to add. So we usually use 3% saline in our units. So that is to provide 3 millimole per kg per day. We add 6 ml per kg per day of 3% saline, which will give the daily requirement. And potassium also the same. We add 1 ml per kg per day of calcium and calcium 4 ml per kg. So this chart also from the national guidelines for newborn care volume 1. So again, so what are the TPN available in Sri Lankan setup? So we have intralipid and as well as Benelec and aminogate preparations. So time to time we get different preparations, but these are the common preparations that we get. And so this is the guideline to start proteins and lipids for the baby. This is again from the national guidelines for newborn care volume 1. So which will give the volume to be started. So day 1, so we have to start proteins. So that is 1.5 grams per kg per day, then 25 ml per kg per day. Then day by day we increase up to 60 ml per kg per day or 3.5 grams per kg per day. And intralipid, so that is again we start within 72 hours ideally. So day 1 to 2 we can start at 1 gram per kg per day, then increase to 3 grams per kg per day gradually on daily basis. So, so parenteral nutrition, as I said earlier, so we should start on day one. So specifically, the protein and lipids are considered less than 32 weeks and 1500 grams in local setup. But if more than 32 weeks and more than 1500 grams, but still less than, if it is a preterm baby, we may consider enteral feeding with 10% dextrose first. If we need 10% dextrose, yes, we consider 10% dextrose. Then we try enteral feeding in the form of cup feed or gastric feed, or even we can try direct breastfeeding cautiously, because as the baby is less than 34 weeks, but the sucking reflex is there after 28 weeks, which will be mature by 34 weeks. So we have to be cautious. We are doing direct breastfeeding, but most of the babies are successful in achieving that. But if we have an instance where baby requiring IV feeds more than 3 days for a baby, like more than 32 weeks, so then I think it's better to start protein and lipid, consider protein and lipids as well for the TPA and other surgical. So even a term baby, if we consider giving, if we are thinking continuing IV fluids for weeks, for more than 3 days, I think it's better to consider protein in the IV fluids. So the protein requirement I already discussed with the lipid requirement. So these are the lipid requirement, the protein requirement, and this is the way to start this. So administration of parenteral nutrition. So how can we administer it? So there are studies show that it's safer to start peripheral food in parenteral nutrition to start in the peripheral. It's safer. There are some local studies as well. So ideally, if the fluid osmolality less than 100 milliosmol per liter, so it's safer to give via peripheral line. Why we consider peripheral? Ideally, I think if the central line is there, yes, definitely yes, we can use that. But parenteral nutrition per se, we don't have to consider an IV line. But in special circumstances, if the patients are there, then we consider central lines. So why we use peripheral lines? Because you know that's it. Keeping unnecessary line or central line, sometimes it's used higher mortality and higher morbidity. So we have to reduce the infection risk and etc. So if we have a foreign thing, so it's always we asking for trouble. But if we can use without the central line, yes, we can use the peripheral line, provided the peripheral cannula is in a good way and flushes beautifully, and there's no concern with ingestion site. So and as well as nowadays the technology and the knowledge is advanced. So now we have the pediatric plastic surgeons and the pediatric surgeons are there. So the management of peripheral thrombophlebitis is also advanced. So because of that, it's safely we can use the peripheral for parenteral nutrition. And as I said, so it's there are low caloric loads in the parenteral nutrition, and as well as Himachal also can be used in the peripheral veins. But this peripheral use is limited by the glucose concentration. So maximum glucose concentration in a peripheral line can be used is the 12.5%. We are, if in any case, if we are using more than 12.5%, so like hypoglycemia, so then we might have to definitely have to consider central line for that. So lipid, it's always better to avoid calcium and bicarbonate together to the same lipid line because of the precipitation. And those days we covered the lipid line with aluminum foil, but now we think it's not needed, but it's inconclusive. So what IV access we have? So if you are using parenteral nutrition, so if you are using a central line, so central line will be the easiest access would be VC and VSU if the baby is fresh. So we can start from the day one of birth. So the indication insert a UVC or UVC. So that is less than 100, less than 1000 grams. So we can consider starting, or else the baby is extremely young. We may consider starting the UVC. And also, if we think that baby needs prolonged IV fluids, or if we think that we might have problem with the system, we may consider UVC at the first instance.
Tharanga,
And as well as in unwell babies. Yes.
Tharanga, it's not time to time. It is not very clear.
All right. Okay. So I think, yeah, I'll try to speak louder, but I'm not sure. Maybe the technical. Very sorry for that.
Yeah.
All right. That's all. All right. Yeah. Please. Okay. Right. Okay. Okay. I'll speak louder. Please let me know if I'm.
I think better to
here,
take
right?
better to take computer a little bit closer. I think.
Yeah, I'm a little bit away from the computer. I'll come closer then. Yeah. So if we don't have the UVC or UVC, if the or otherwise if the baby is older, then the options would be peripheral line, or else we can use the PIC lines. So PIC lines to be used. Or if it is more than 1 kilo, we can use 20 for gauge one, and if it is less than 1000 grams, then we may have to use the Premicat for the 28 gauge PIC line. So the preparation, how do we prepare IV fluids for the parenteral nutrition preparation? So it has to be done in full aseptic measures. So ideally, if you are handling a central line, I would say it's always better to do the full scrubbing. Between the advanced setups, they do full scrubbing for handling parenteral nutrition, and the labeling should be there. And the cannula site inspection has to be done very well, and the cannula labeling also very important, and as well as the fluid preparation, it has to be also labeled properly. And in Sri Lankan setup, for the ideally, actually those fluid has to be prepared in a set time. So because if we prepare fluids every time for each and every baby, so that increase the incidence of sepsis, I would say. So reduce the incidence of sepsis, I would say. So we can use the same saline bottle, same 3% saline, same dextrose and calcium preparation. So ideally, if we set a time, so roughly around 9 a.m. in the unit, so we are going to prepare IV fluids. So for all the babies, I think it's better to prepare at a given set time. So in that case, we have to, so as doctors, we have to give the fluid regime or the fluid plan prior hand. So ideally, the night person can do the fluids and give the night fluid plan, so that can be prepared in the morning by the nurses. But during the consultant board rounds, sometimes the consultant may change the fluids. So in that case, in exceptional situations, so those things can be prepared separately. Otherwise, it's a good practice to prepare at the same time. So assume a baby come at 6 p.m. and we prepared IV fluids, but usually sometimes they keep that fluid till 6 p.m. the next day. But rather than that, so better to discard that fluid in the morning, and the same time we can restart new fluid regime, or the same fluid regime can be continued with a new set of fluid. Then we can set the correct timing for every patient. So that will definitely reduce the incidence of sepsis, because then, so my other advice is to discard the leftovers, like saline bottles and the dextrose bottle and the 3% saline. I know that 3% saline will be expensive owing to the current situation in Sri Lanka, but we have to think wisely. I mean, we may use that, but if you are reusing that, please relabel them, and as well as use alcohol wipe to wipe the upper part of the bottle, then only use the setup, and as well as make sure that you are using strict aseptic technique whenever you are reusing the used bottles. And how do you supply those? So we can infuse those IV fluids via infusion pumps or syringe pumps. Always use the infusion pumps if you have, because it's very accurate, and as well as you can give large volume through that. So we can prepare the fluids at for 24 hours, 4 hours almost. Then you don't, because the limitation in the syringe pump, sometimes if we prepare a syringe pump for a term baby, then it may the fluid is not adequate, because the maximum you can send via a syringe pump is 50 ml. So then we might have to prepare fluids 3 times per day, especially for term babies. So always, if you have infusion pumps, use the infusion pumps. Try not to use burettes, but if in any case, if you can't find an infusion pump or syringe pump, invariably you have to use the burette sets, because burette sets are not accurate, because it has to be the rate has to be set manually, so it's not accurate enough. That's why. And so discard leftover bottles, as I said earlier. Yes. And the monitoring. So how should you monitor a baby when the baby is on IV fluids or the parenteral nutrition? So always, as I said earlier, the cannula site, very important. So always look for the cannula site infection, erythema, swelling. If you have a slight doubt, please remove the cannula and site another cannula in a different way, ideally in a different hand if possible. But actively look for the possible complications. And as well as, so as I said earlier, always try to put a large bow cannula always, and use the technology. Some units may have the infrared lights for the IV cannulation. So which is, I think if you use that, it will reduce the time to cannulate, and as well as number of attempts, and we can use more distal veins frequent. So always use the technology and site the cannula with a large cannula, so that will reduce the handling time of the baby. And so when we are plastering, I know most of the units we use those, but unfortunately we don't have the capacity. But if you have facilities, if you can afford, or if you can locally purchase tegaderm plasters, please use them. So please use the plaster above the cannula site, then you can see the insertion site, so easily you can identify complications early. So that's very important. And as well as the monitoring wise, the hemodynamic parameters should be monitored in the baby. So the like heart rate, the capillary clean time, blood pressure, urine output, etc. So if facilities available, even you can use urine specific gravity, and the osmolality also can be used to decide on the fluids. So, and weight measurement, as I said earlier, if facilities available, use the inbuilt weight scale in the incubators, but otherwise the manual scale has to be used. So daily weight scale, weight is the ideal thing for extreme preterms and the newborns, sometimes 2 times per day in exceptional cases. Then you can space out the monitoring later on. Once the baby is stable, you can space out weighing frequency. And other than that, sugar has to be monitored 6 to 8 hourly, depending on the circumstances. I mean, depending on the clinical situation. If baby is hypoglycemic or hyperglycemic, we may have to monitor more frequently than that, but otherwise 6 to 8 hourly monitoring would be adequate. And electrolyte, ideally it has to be done at 24 hours. Within 24 hours, we have to do electrolytes, creatinine, blood urea. That reflects the maternal results. So that may give some idea about if the creatinine is persisting, if it is not dropping. So that gives some suggestion for the acute renal injury. And as well as so we can see the trend. So it's so ideally it has to be around 24 hours, but in our setup we usually do by day 3. Then once it's stable, then we consider twice weekly, likewise we do that. So while on parenteral nutrition, sometimes we do consider doing liver function test and bone profile weekly, but bone profile usually we do after 28 days of life. But in special circumstances, if baby is requiring total parental nutrition for, prolonged chronic usage, more than 2 weeks of usage, then we might have to do early bone profile and those things. And if baby is hyperglycemic, yes, we have to consider doing urine sugar to see to exclude osmotic diuresis. And what are the complications of parenteral nutrition? So line-related sepsis, thromboembolism, and liver complications. It's rare, but sometimes they may get cholestasis due to prolonged TPN usage. It can be managed easily. Sometimes it feels self-resolving, and sometimes we may have to consider sodium folic acid for the management. And as I said earlier, hyperglycemia also a complication. So if you give adequate amino acids, it will reduce the hypoglycemia because it will stimulate insulin secretion. And as well as lipids also promote hyperglycemia as well. So enteral feeds while IV fluids. So when do we start enteral feed in an extreme preterm baby or a preterm baby, or else a baby who required IV fluids initially? So sooner the better. So when the baby is stable, yes, we do start. And if contraindications are there, like surgical conditions or some other, especially surgical condition, then we may stop trophic feeds for a while until the surgically cleared, or sometimes severe sepsis like necrotitis, necrophilitis, then we may have to stop feeds until the baby is stable. So initially during the preterm period, so we do start trophic feeds, so sooner the better. So if preterm delivery is imminent, I would say if possible, express some milk before the delivery and keep it in syringes, or else we can keep them on fridge and we can utilize them later on once the baby is born. So which is very important, which is happening in other countries. So I think we should practice that in Sri Lankan setup as well as possible. So trophic feeds is like it is given at the rate of 20 to 24 ml per kg per day, so in divided doses, so that will stimulate the gut, and as well as it will reduce the risk of sepsis and risk of neck, and it will increase it will reduce the risk of neck, etc. And so how should we increase the feed, the enteral feeds? So it's depend on the clinical situation. If baby is stable and baby is tolerating feeds, and the baby is on trophic feeds and tolerating, we can increase feeds. So initially, if the baby is small, preterm, extreme preterm, then we may increase by 10 to 20 ml per kg per day in divided doses. But if a term baby or a big baby, preterm, late preterm baby, we may increase feeds. If we don't have any concern, we may increase feed quickly, like up to 40 ml per kg per day, even we can try. And so always, if we have doubts, you have to so feed intolerance. So if we have doubts, you have to examine the baby clinically. So what are the doubtful features, like abdominal distension, visible bowel loops, and shiny abdomen, tenderness, very important. So tenderness might be the early feature of neck, and as well as bowel is not open and feed is not tolerating post-setting or vomiting or gastric residue. So if you check the aspirates, so there the gastric aspirate is there. We shouldn't check routine gastric aspirates in a neonate who's on advancing enteral feeds. That's the recommendation, but still some units in all over the world, some units they practice doing that, but evidence is they are not to check gastric aspirates unless there is an indication like feed intolerance or abdominal distension or anything. So preterm babies, sometimes they may have bile stain, lightly bile stain aspirate, so that is fine provided the examination findings are reassuring. So in that case, we push feeds, and so that might increase the gastric motility and the tolerance will be improved. So when to stop parenteral nutrition? So in our practice, so we can stop protein and lipids once 50% of enteral feed is achieved, and once the 2/3 of oral feed is achieved, we may stop IV fluids as well. So let's do a practice example for fluid calculation. So which has to be done in ICU setup in daily basis, especially by the night doctor. So this is a 29-week male infant. Birth weight is 1 kilogram, and the current weight is 950 grams. So now the baby is on day 3 on CPAP and on trophic feed still, and on antibiotics for suspected early onset sepsis. And sodium is 133, potassium is 3.7, and blood gas is satisfactory. So how to prescribe the maintenance fluid for this baby? So according to our ministry or the national guidelines, so for a day 3 baby, we have to give 110 ml per kg per day of fluid. So we take the birth weight for the calculation. So we need to give 110 ml of fluid for the day. And we gave a trophic feed, so it's around 24 ml kg per day, so 2 ml 2 hourly, so that comes to 24 ml. So enteral feeds 24 ml is given. And proteins, according to the guidelines, so day 3, the requirement is 2.5 grams per kg per day, which comes to 43 ml per kg per day. That's come to 1 kilogram baby, so 43 mils. And the lipids 2 grams per kg per day, that is 10 mils. So day 3, now we are going to start electrolyte as well. So this baby had postnatal diuresis and as well as weight loss is there. So we are starting electrolytes in this baby. So sodium chloride. So in our practice, we have 3% saline, but in other countries, other preparations are there like 23.4% saline or 30% saline. But in our practice, it is 3% saline. So 3% saline, the requirement is 3 to 4 ml per kg per day. So we will start at 3 millimole per kg per day. So that comes to 6 ml per kg per day. So the fluid is 6 ml. And the potassium is 2 millimole per kg per day. That is again 1 ml per kg per day. So 1 ml, and calcium 4 ml per kg per day. And so altogether, if we calculate and minus, so if we add all these things and if we minus it from 110 total requirement, that will give the 10% dextrose requirement. So this is the 10% dextrose requirement, and the drip rate would be the IV drip rate. It has to be minus EBM rate. So 110 minus the EBM trophic feeds 24. So divided by 24 again. So that gives the hourly rate for the baby for that day. In addition, sometimes we may use the central lines, the UAC. We might do 0.5 ml of halves normal saline, or sometimes we might be on inotropes, sedation, or sometimes if we need strict fluid restriction of strict input-output chart, then we may consider other drug infusion rates also, like if we give antibiotics, some antibiotics may need large volume, so those things also need to be calculated for the fluid. Assume this, assume if we run out of fluid, so once we calculated, once we added everything and we don't have any dextrose to be run. So in that case, the options would be, so we may consider reducing the proteins. We can come down one or two steps downwards, and then we can reduce the fluids. Or else, sometimes if we use inotropes or sedation, so we can double concentrate. Then we can preserve some fluid and give some dextrose. Or even sometimes, if we want to give dextrose, so always try to prepare, if possible. I mean, if no contraindication or if no other issues, you can prepare them with 10% dextrose, the other fluid like inotropes and the sedations. And what are the special situations? So in hypotension or resuscitation, during resuscitation, the initial manager, if baby requiring IV fluids, if we decide to give IV fluid, a bolus, then the fluid would be a normal saline 0.9%. So that is 10 ml per kg. First we give, and then we assess the baby for the requirement for further boluses. And in babies with intestinal obstruction, where we keep the baby in NG-free drainage, and as well as if the baby is having a stoma and we are getting stoma loss, and the baby is shortcut and having aspirates. So then those aspirates should be monitored, and strict input-output chart has to be monitored, and aspirate should be monitored. And those aspirate, if it is ideally, if it is more than 20 ml per kg per day, if the aspirate is more than 20 ml per day, we should replace them meal by meal every 6 to 8 hours over 2 to 4 hour period. So if we are using a replacement fluid, again we have to use sodium chloride 0.9% with added potassium for the bag. Other special situations are the electrolyte imbalance, the hyponatremia, which is a very common entity in the early neonatal period. So as I said earlier, we anticipate postnatal diuresis. Sometimes in some babies, these postnatal diuresis won't happen correctly because of the immaturity and as well as the impermeability of the capillary membranes. So rather the diuresis, they lose extracellular fluid into the interstitial fluid compartment, and fluid accumulation happens. So, and as well as dilutional hyponatremia can happen. So in those situations, so it is guided by the urine output and as well as the urine osmolality and as well as fluid status of the baby. If fluid overload is there clinically, then we shouldn't advance fluid, and as well as we shouldn't give further sodium, especially in conditions like if a baby is having suspected SIADH, syndrome of inappropriate ADH secretion, especially in instances like respiratory distress syndrome, congenital pneumonia, or intraventricular hemorrhage or NSDNS insult. So in those type of conditions, baby might at risk of having syndrome of inappropriate ADH secretion. So in those babies, they have fluid overload and as well as dilutional hyponatremia, and they may pass less urine, and the urine also concentrated. So in those babies, we have to restrict fluid rather than giving fluid and sodium. So if we are on one, so we can restrict fluid to 2/3 of the maintenance. And there are some instances with hyponatremia and weight loss. So in those instances, so we have to find the fractional excretion of sodium in urine. So if the fractional excretion of sodium is high, so that means that sodium is losing. In those babies, we may have to supply sodium for the hyponatremia, and as well as we need to find a cause. Sometimes hyperglycemia might be the reason for that. So a hyposmolar state, so losing water, with water, sodium also losing. So in that case, if we treat hyperglycemia, the hyponatremia also automatically settles. So the other instance is the hypernatremia. So again, hypernatremic dehydration is the common entity in the early period of the neonates. So that is because of delayed establishment of breastfeeding, and as well as if you are not providing adequate fluid when the extracellular fluid contraction happens. So the common scenario is in a term baby who present at day 3 or day 5, day 4 to 5 of age with more than 10% weight loss, and at the same time urine output also less. Very aggressive, some depending on the clinical scenario. So aggressive baby looking for feed, but the feeding is not established properly. So in those baby, if we check urea, blood urea will be high, and as well as sodium will be high. So hypernatremia and the dehydration features are there. So management would be, so depending on the sodium level. So if it is mild to moderate, like the hypernatremia up to 160 up to 160, so we can manage with breastfeeding provided the baby is remaining stable, I mean clinically stable, and breastfeeding is good. And if we give a breastfeeding target with the EBM target, direct breastfeeding plus EBM target, we can manage easily. But sometimes moderate to severe hypernatremia can happen if the levels are more than 160. In that case, we have to be careful. So if in any case, if we are starting IV fluid, so fluid. So if dehydration features is there, definitely yes, give a bolus 0.9% sodium chloride, 10 ml per kg, and then reassess. Then subsequently you have to calculate the fluid deficit. So usually the weight loss equals the fluid deficit. Assume a 3 kilogram baby now comes at 2,400 grams. So 600 gram weight loss. So we can assume that the fluid loss is around 600 mils. So we can reduce the initial fluid bolus we have already given. The most important thing is when we are correcting sodium, we have to be careful. We shouldn't reduce the sodium quickly. So it has to be reduced slowly, gradually. So the ideal rate of drop should be 0.5 millimole per hour. So roughly 12 millimole per day. So 10 to 12 millimole per day is our target. So there shouldn't be rapid drop because there's risk of cerebral edema and causing seizures in the baby. And so because of that, we have to be careful. So in moderate to severe hypernatremia, if we are considering a fluid, so we shouldn't give hypotonic fluid. Hypotonic fluid in the sense we shouldn't give free water. Ideally, free water should be given, but we have to give some sodium as well. So ideally, 0.9% saline should be added to the fluid. The fluid should contain that and plus 10% dextrose. If it is up to above 160, up to 160, even 160 to 170, we can consider 0.9, provided the drop is not more than 0.5 millimole per day, millimole per hour. And if we get, if severe hypernatremia, like more than 175, if severe hypernatremia is there, we have to be very cautious. Then the drop should be very gradual, has to be very gradual over 48 to 72 hours. So in that case, the fluid should have some sort of sodium, not only sodium chloride 0.9%, because sodium chloride contains 154 millimole per liter. So our value is 174. There's a huge gap. So that gap should be about 10 to 15 millimole per liter. So accordingly, we can calculate the sodium deficit. There are formulas for that. And accordingly, we can select the fluid. So once we started fluid, always if moderate to severe hypernatremia, we have to check sodium levels 4 to 6 hourly, and depending on the value, then we can adjust the fluid. If the drop is not adequate, we can increase fluid, but if drop is more than adequate, more than 0.5 millimole per hour, then we have to reduce the fluid rate. So we have to cautiously do that. At the same time, we can start give an EBM target, and as well as direct breastfeeding, we can try. And sometimes the hypernatremia can be iatrogenic. Sometimes we may have given additional, the fluid wrongly, but that's rare. Hyponatremia also sometimes, that's previously I discussed the early part. So the latter part, later during the neonatal period, after 2 to 3 weeks, because of the renal immaturity, especially preterm babies, they may lose sodium because of the renal immaturity. In that case, we may have to give oral sodium. So oral sodium can be supplements once the baby is on full feed. So we can give 3% saline. Our preparation is that at the moment. So we can calculate the deficit. So like 3 millimole per kg per day, 6 millimole per kg. Likewise, we can calculate 1 ml of 3% saline contains roughly around 0.5 millimole of sodium. So likewise, we can roughly calculate and we can give in divided doses. So then we can check electrolytes in 3 to 4 days time. And so those are the things. So these are my references. And thank you. And any questions?
Thank you very much, Tharanga. Very comprehensive presentation. We have 2 questions. First question is that fluid volume should not be set for 6 to 8 hours for once, Is it okay for total 24 hours? I think they're asking about that preparing fluid for 6 to 8 hours.
Yes, yes. I think always, if possible, prepare it for 24 hours. But if you are giving, I mean, if it is if you are giving via an infusion pump, then that would be easy because it's reduced the chance of inspection and infection, and as well as reduce the handling time. So I think it's better unless it's changed during the daytime. So I think it's better to prepare for 24 hours rather than every 6 to 8 hours. If you can, if your unit can practice that practice, so I think you can reduce the incidence of neonatal sepsis for sure.
Yes, thank you, Tharanga. There is another question, but before that, if you all have a question, you can raise the hand, then I can unmute, then you can talk and you can talk. The second question is, in hypernatremic dehydration, can we give breastfeeding? If yes, breastfeeding volume.
Yes, obviously, breastfeeding we can continue. If baby is stable, I mean, if it is moderate to severe hypernatremia, baby might be very sick. In that case, we might not be able to give direct breastfeeding, but still we can try give EBM. But it's possible to give breastfeeding. Always give breastfeeding. That's the easiest way to manage. If it is mild to moderate, that's the easiest way to manage. So if you are giving breastfeeding, the volume should be, I mean, so EBM, we can give a EBM target. So assume the baby coming day 4, so we can give the full feed. We can give a full feed target because usually they come with delayed establishment breastfeeding. Maybe their breast milk secretion is not adequate. So in that case, sometimes we won't be able to get that much of volume. But if you give a target and give the proper support, we may be able to get. But if you are starting IV fluids, I think it's better to start 2/3 of the maintenance to reduce the incident. I mean, to reduce the chance of quick correction of hypernatremia.
Thank you, Tharanga. There's another question. What is the fluid management of phototherapy? Count into single or double phototherapy?
So, because of the current, I mean, for the phototherapy machine, I think most of the units now we have LED setups, LED lights we have. So it causes very less amount of fluid loss and heat loss rather. Heat loss. Because of that, we don't have to consider fluid therapy, additional fluid for phototherapy per se, but in extreme preterm babies, we may have to consider if excessive weight loss is anticipated. If we check when we check the weight, if the excessive weight loss is there in on double or triple phototherapy, we may consider adding additional 20 ml per kg per day of fluid. But routing fluid, I don't think that we have to give because of the LED lights that we are using. But again, if depending on the environmental temperature and everything, and if the temperature is relatively high, you may consider. But as LED light, well, I don't think so.
Yeah, I think question-wise, that's all. If you have any question, you can ask now. You can raise the hand, then I can unmute.
Tharanga,
Yeah.
Tharanga,
Yes.
thank you very much for your presentation. It's very informative. You highlighted the importance of starting parenteral nutrition from day 1 onward, because it was very important to reduce the postnatal growth failure as well as the improvement in the neurodevelopment. So there's one thing I just want to clarify with you, Tharanga. Now, when there are nasogastric aspirates, we tend to replace with Hartmann solution.
You mean nasogastric aspirates in a surgical baby? In a surgical baby or just routing preterm babies? Hello, Dr. Gitma. Dr. Gitma, are you there?
Yes, Tharanga. I can hear you.
Yeah, is it in the surgical babies or gastric aspirate in surgical babies or preterm babies? So if I think question is whether to replace with Hartmann solution if gastric aspirate. So if it is surgical baby or a stoma, having a stoma and having frequent aspirate, so Hartmann also a good choice to select because it contains some fluid and it is almost similar to the plasma. So Hartmann also can be used, and or else sodium chloride, 9% sodium chloride with added potassium also can be used. But some units, some use just sodium chloride or only as well, with frequent monitoring of serum electrolyte with potassium low, then they will add potassium. But if it is in a preterm baby, sometimes we might get large aspirates, NG aspirates. In that case, sometimes we may consider, not absolutely we are not replacing, but we may consider, if it is a large volume, we may consider replacing those volumes because we anticipate electrolyte loss. But we can do electrolyte and see whether there's a loss, absolute loss, then only we can think of replacing.
Yes, thank you, Tharanga. There is, I think, Nishadi wants to ask some question. Nishadi, you can ask now.
Excuse me, sir. I'm one of the ECMO. Sir, frequently we have seen some neonates presented with hypernatremia. Currently on formula feeds, on breastfeeding plus formula. In that case, how can we manage present with hypernatremic dehydration? Can we continue formula feed?
Yeah, I think the hypernatremic dehydration happens because of delayed establishment of breastfeeding. So the best thing would be to avoid formula as possible as we can, because you know the complications of formula and the disadvantage of formula over breastfeeding. So we can jolly well manage the baby with the breastfeeding alone, breastfeeding with EBM, so with a proper support, and we can manage jolly well, I think. So so always better to use the natural things rather than the artificial things. If you are getting some artificial thing, it's always asking for trouble. And if in any case, if the baby is on formula, so first check the preparation. So sometimes the concentrated might be the concentrated formula causing hypernatremia. So always you have to, because some mothers may give concentrated formula. So always check those things as well when you are giving formula.
Yes, Tharanga, there is another question. How to analyze fluid balance in a very preterm baby?
Yes, the analysis of fluid balance in very preterm babies all depend on the clinical scenario. So best thing would be whether baby needs fluids or not. So how can we decide? So best thing would be the postnatal diuresis, as I said earlier. So monitor urine output. So you can monitor the urine output by measuring the nappy, the weight of the wet nappy, and as well as the weight loss. If you measure the weight loss, then you know that baby is losing weight. Other than that, some clinical parameters that guide the fluid therapy would be the heart rate. If the baby is tachycardic, if you excluded other possibilities like sepsis, possible open PDA, hemodynamic significant PDA, pain, etc., then that might be an early clue for dehydration. And as well as the capillary refilling time, if it is more than 3 seconds, so that is baby is dehydrated. But those are sometimes the clinical parameters are not very much evident in a baby dehydration. Features are not very much evident, like sunken anterior fontanelle. So the blood pressure drop also a late finding, so we shouldn't wait till the blood pressure drop. So those are mainly the weight loss, postnatal diuresis, weight loss, and the heart rate. You can guide you can use those as a guidance for fluid therapy. If weight gain is there, we shouldn't increase fluid. So that's very important, as I said earlier, because that will increase the incidence of PDA, persistent PDA, and as well as necrotizing necrophilitis, and as well as the risk of developing pulmonary dysplasia.
Thank you, Tharanga. There's another question. Do we need to adjust serum potassium level if serum creatinine high? due to maternal serum creatinine effect initial 7 days.
Yes, I think if you do an early serum electrolyte and if you found serum potassium is high, always, avoid fluid. That is the main thing that you want to do. Then afterwards, so monitor the serum, monitor the baby clinically with ECG monitoring and try to find whether there are any ECG changes. If you found any ECG changes, yes, you have to give calcium gluconate to stabilize the myocardium. And then you may have to consider treating the baby with hyperkalemia according to the hyperkalemia management, maybe it's with dextrose, etc. But sometimes it might be the hemolysis sample, because you know that taking a blood sample is very difficult sometimes, and you may squeeze the vessel. So in that case, the hemolysis can happen, and if the sample is left for a long time, the hemolysis also again happen. So always assess the situation and decide. And if you have clinical evidence of hyperkalemia, and if you have ECG changes, yes, I think you have to better to treat.
Okay, thank you, Tharanga. I think we don't have any other questions. Thank you very much, Tharanga, for your comprehensive presentation, and thank you all of you for your participation in this very important webinar. And again, I would like to thank Astron Pharmaceuticals for their support for this program. And Tharanga, another question. Dr. Kapilani wants to ask one question.
Yes.
Yes, madam. You can ask your question, madam. Hello, Kapilani, madam. Hello. I think it's not clear, Tharanga. Anyway, thank you very much for your presentation. Yes, Kapilani, madam. Yeah, there is a message. She wants, please pause the recording to recording in the group. Thanks. That is Kapilani madam's message. Yes, madam. We will post the recording tomorrow. And the other thing, Tharanga, there is another request from the audience. They want your presentation, and they ask whether is it possible to upload this presentation to a WhatsApp group or not.
Yeah, I will send it to you.
Okay. Okay. Then thank you very much, everyone, for your participation. Yeah, we will meet after 2 weeks.
Right. Thank you.
Thank you. Thank you, Tharanga. Thanks, Deepa.
Thank you.
Okay.
Thank you. Please. You can leave.